Good evening, everybody. My name is Roxanne Chabot from RBC Consultants. This evening, we're going to talk about a practical subject, itch, hives, and allergies. Our speakers are going to share with you treatment strategies for adults and children. As speakers, we have Dr. Jackie Rao, who is Clinical Professor, Division of Dermatology and Cutaneous Sciences at the University of Alberta, and Founder and Medical Director of Telederm Canada. He is a board-certified dermatologist. We also have Dr. Gordon Sussman, who is Professor of Medicine, Staff Division of Allergy and Clinical Immunology, St. Michael's Hospital in Toronto. We'd like to thank Moravo for making this educational event possible. Before we begin, a couple of technical tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in and send it back to us. Within 1 to 2 days of the webinar, the recording and a certificate of attendance will be emailed to you. Again, if you want to submit your questions using the question chat pane on the right-hand side of your screen, our faculty would enjoy receiving your questions at the end of the webinar. And I've written a little note there so that you can see where you need to type in your questions. So without further ado, I will pass the floor virtually to Dr. Gordon Sussman.
Hi, everyone. Good afternoon and good evening. Pleasure to being here, and I'd like to acknowledge Aralaz Moravo for sponsoring this. I'd also like to thank Roxanne for doing such a tremendous job as she always does. And it's a pleasure doing a program with Jackie, and hopefully you'll find this beneficial in terms of you'll learn something from it. Without any further comments, we're going to go to the next slide, please. We're going to start with a polling question. This is a question on allergic rhinitis. So we would like to know, how do most people commonly treat pediatric allergic rhinitis? This would be the first line treatment. So if you could please select one from the following: first generation antihistamine, second generation antihistamine, nasal steroids, or allergen specific immunotherapy. This is an important question because it's a very common condition that you're treating, and it's good to know how people treat. So please submit your answers now, and really appreciate it. The answers are a little surprising. 18% of people still would treat as a first line with first generation antihistamine. So hopefully those people will learn from this discussion. But the good thing is the majority of people will still treat with second generation antihistamines as first line treatment. Roxanne, next slide, please. Next slide, please. The next slide, please. The pathophysiology of allergic rhinitis is IgE-dependent hypersensitivity. That means IgE binds to mast cells, triggering histamine release and release of other mediators, which cause increased vascular permeability. This results in itchiness because nerve endings are triggered by histamine, but also stuffiness because the nasal mucosa gets edematous, and running and sneezing. These are the cardinal manifestations of allergic rhinitis. Often associated with it is allergic conjunctivitis, where the eyes get itchy and watery, and comorbidities also include atopic dermatitis as well as asthma. And the point on the right is important because we're going to be discussing the pediatrics. It's the same mechanism. Allergic rhinitis is the same in children and in adults. Next slide, please. Allergic rhinitis is a common condition. It's one of the most common conditions that we treat. It's present in 25% or 20%, 20 to 25% of the Canadian population, and children are more commonly affected than adults. In some countries, allergic rhinitis has a prevalence of 40% in total, so it's a very common condition. Next slide, please. Allergic rhinitis is just not like a nuisance like you watch on the commercials. It just doesn't cause your nose to run and your eyes to itch, so you're scratching and sneezing all the time. It actually affects your life. It affects your overall quality of life. With allergic rhinitis, you have difficulty sleeping, you feel irritable, and your emotions may be difficult, so you can't concentrate, and you often feel tired. And because of that, you don't perform optimally. There's studies showing that you can more likely to fail an exam if you have allergic rhinitis than if you don't. So it's a condition that is often trivialized, but it's a condition that should be treated and should be treated properly. Next slide. This is the algorithm that we started with in terms of first-line treatment. The primary treatment is allergy avoidance, but people have to breathe, so it's hard to avoid pollens and dust and molds, but pet dander is something that is potentially avoidable. And we try to use measures so people minimize the exposure to their allergens during the season by, for instance, keeping the windows closed and using the air conditioner. For dust mite, you want to control the indoor humidity, get rid of dust collectors, take out carpets sometimes, wash the bedding in hot water. There's measures you can do. Nasal steroids are our primary treatment, and they're very safe. When we treat allergic rhinitis with antihistamine and nasal steroids, you like to start just prior to the allergy season and continue right throughout the season for about 2 months, and that way you'll get optimal benefit from the available pharmacotherapies. If you look from the bottom down, you also can treat with leukotriene antagonists and allergen-specific immunotherapy. Immunotherapy can go up or it can go down. Some people would prefer immunotherapy because it treats the allergy, and with time, it has potential to modify the disease. There's different types of immunotherapy available. There's pre-seasonal immunotherapy, which can be given by sublingual method or by subcutaneous method. So there's a lot of choices in terms of the treatment of allergic rhinitis. But the approach to treatment is identical both in children and in adults. Next slide, please. And this is the Canadian guidelines. Peter Small was the first author. As the society, the Canadian Society of Allergy and Clinical Immunology published a statement in 2019, which basically stated that we only recommend newer second-generation non-sedating, non-impairing antihistamines because they're safer than first-generation antihistamines. And they should be used as first-line treatment for the allergic rhinitis and urticaria. First-generation antihistamines have significant side effects. We know when we take a first-generation antihistamine like diphenhydramine or Benadryl that you will get drowsy an hour later, or 2 hours later, but you do not recognize the impairment that happens because you do not get a good sleep quality. You get a non-REM sleep and you wake up in the morning unable to process and more likely to fail an exam. From allergic rhinitis, it's 40%, and if you add a first-generation antihistamine, it's almost 3/4 of the people that drop a grade. So it's very significant. And you're also more likely to get into car accidents, or if you're a pilot, get into a plane accident. So the impairment part of antihistamine is something, first-generation antihistamines is something that is really under-recognized even today. It also is non-selective, so it can aggravate adrenergic receptors, which results in dizziness and orthostatic hypotension. It may have anticholinergic effects, which cause dry mouth and urinary retention. It can activate or block dopamine receptors and be responsible for weight gain. The first generation antihistamines are not specific. They're not very good at recognizing just histamine receptors. The bottom line in the blue is very important, not the yellow. This has resulted in death from car accidents. So you're 1.5 times more likely to get into a serious car accident under the influence of a first generation antihistamine. And it was also responsible for fatal plane accidents. When they looked at it, it was up to 11% of pilots had first generation antihistamines. It just wasn't recognized. Overdoses are also an issue, and often it's used in children. So a lot of these overdoses occur in children. Because of the anticholinergic effect, it may result in coma and even death. So some of these overdoses can be very serious. And finally, sudden cardiac death can occur. As a class, antihistamines can prolong the QT interval. It just wasn't recognized in the 1940s and 1950s when first generation antihistamines were first brought into practice. But they all have the cardiac effect, and by prolonging the QT interval, they make you more susceptible to cardiac arrhythmias. Next slide, please. This is a very useful study because of the size of it alone. It was the Finkel study that was published in the Annals of Allergy in 2002. So we knew the effects of first generation antihistamines a long time ago. This study involved 12,000 patients treated with diphenhydramine or Benadryl and 24,968 patients treated with loratadine or Claritin. And they looked at injuries the year that they were treated with the antihistamine and the year after. And you can see with loratadine, which is the blue, there was not much difference in terms of injuries, whether it was fractures, crush injuries, wound injuries, or burn injuries. But when you were taking a first generation antihistamine, in this instance, diphenhydramine, you see significant increases in all types of injuries. And that's because of the impairment that I was talking about in the previous slide. And again, this would not have been recognized if it wasn't studied specifically looking for injuries. Next slide, please. Second generation antihistamines have been a very significant advance in the treatment of allergic rhinitis and urticaria, as we'll see as we go along. And if you look at the antihistamines available in Canada, there are 3 prescription antihistamines: Bilistine, which is marketed as Blackstone, cetirizine, which is Reactin, and rapidine, which is Rupall. There's 4 over-the-counter second generation antihistamines: cetirizine 10 milligram, whereas the prescription is 20 milligram. Arius, which is desloratadine, Allegra, which is fexofenadine, and Claritin, which is loratadine. If you look at the pediatric indication, you can see that all but Allegra have the pediatric indication, and I'm going to review that later on in the talk. Suffice it to say that 80% of drugs that were approved prior to 1997 did not have the pediatric label because of difficulty in extensive and expensive research in the pediatric population that was required. But since 1997, there has been studies that have been done, and I'll go over the antihistamines that have the label, the pediatric label for allergic rhinitis and urticaria. So again, 3 of second generation antihistamines are prescription, 4 are available over the counter, and 5 have the pediatric indication. You have a choice, and they're all much better than first generation antihistamines. We should not be using first generation antihistamines. This slide is from product monograph data. I'm not a big proponent of product monograph medicine, but I will show this just to illustrate the differences on the monograph and review what I think is important. So if you look at the indication for Bilistine, it's greater than 4 years of age with a weight of 16 kilograms for both allergic rhinitis and chronic urticaria. For rapidine, it's greater than 2 years, and for cetirizine, it's greater than 2 years. Contraindications, if you read the product monograph, it says people who have a history of QT prolongation or torsade de pointe should be careful with Bilistine and Repatidine, and there's a warning on it. But in fact, these two antihistamines have been very carefully studied for QT prolongation. Even at 5 times the dose of Bilistine, you will not see any prolongation of the QT interval. So if you take it with a macrolide antibiotic or an antifungal, you won't see a longer prolongation of the QT interval. If you remember back to 1980, Sedating and Histamine were the first second-generation antihistamines available. They were taken off the market because of QT prolongation. It wasn't really recognized, and because of that, and because it was reported, they had to be taken off the market, whereas first-generation antihistamines are still on the market, so you have to be aware of that. The onset of action, when the drug is excreted, you see a faster onset of action. So for instance, Bilistine and Cetirizine have an effect within 20 to 30 minutes or up to within an hour, whereas Repatidine has an effect within 2 hours. It has to be metabolized before it has an active effect. So generally the onset of action is a little bit slower. Next slide, please. Bilistine is excreted. It has its own, it has a different elimination pathway called the B-glycoprotein and absorption called the OAT pathway, whereas Repatidine is metabolized by the cytochrome P450, and as such, because many drugs are metabolized, have the potential for drug-drug interactions. So it's not recommended for patients who have significant renal or hepatic impairment. Cetirizine is less extensively metabolized. It's actually excreted primarily in the kidney. Bilistine is excreted 1/3 in the kidney and 2/3 in the feces. So there's a bit of a difference between elimination for Cetirizine versus Bilistine. Drowsiness has been reported, and I think we all know that Cetirizine or reactant is sedating. So about 10% of people are drowsy by 10 milligram and about 20% by 20 milligram. And if you quadruple the dose like we do in chronic urticaria, almost half of the people will be drowsy with Cetirizine. If you look at Repatidine, there are some studies that have picked out a signal with drowsiness. Again, it's a non-sedating antihistamine, but there's some studies that pick up a sedation signal. Whereas if you look at Bilistine, you do not see sedation in any of their studies as being reported more frequently than placebo. The effect with food and grapefruit juice is that Bilistine absorbs 1/3 less. So you have 1/3 less in your blood when you are taking it with food. Whereas if you take Repatidine with grapefruit juice, you see an increase of 3.5%. I have more concern about increases because of toxicity and the potential for drug-drug interactions than I do for drugs that have a lower effect, because you can always increase the dose if you need to, if you're absorbing a little bit less. Food has no effect really on Cetirizine, although it says it may slow absorption. It's not really significant. Next slide, please. What's new in prescription antihistamines? And again, because this is I'm going to be presenting mainly Bilistine data today, so just so you're aware, most of the data I'm going to present is Bilistine data. Next slide, please. Now, this is Bilistine on one slide, right? Bilistine is Blackstone again. It's not derived from a metabolite. It's a novel new medication. For instance, Cetirizine, which is reactant, is the active metabolite of hydroxyzine, which is Atarax. So it's not surprising that it's sedating. Fexofenadine is the active metabolite of Sedating, which was taken off the market, but it's a good drug and it's an active metabolite and it's non-sedating and non-impairing. Desloratadine is an active metabolite of both Repatidine as well as Claritin or Loratadine. So a lot of these newer antihistamines that came on the market are active metabolites, whereas Bilistine is a novel molecule. It does not cross the blood-brain barrier, so it does not cause drowsiness, does not impair functional performance. You can drive, you can fly, and it does not potentiate the effect of alcohol or sedatives. It's not metabolized. It's excreted primarily 2/3 in the stool and 1/3 by the kidney, as I said, and the bioavailability is dependent on different transport pathways. Now, there are drug-drug interactions with the P-glycoprotein, just not as many as with the cytochrome P450. The safety, again, is equal to placebo. You don't really need dose adjustment in hepatic or renal failure unless it's end-stage renal failure. And no dose adjustment is required for the elderly people. That's defined as greater than 65 years of age. Next slide. So recently, Bilistine was approved for children 4 years of age and older. Bilistine was first launched in Canada in 2016, and last year it received the pediatric approval. There's 2 formulations and 2 different flavors. There's a suspension, which is raspberry, and there's a quick melt tablet, which is cool because it dissolves very quickly and it's grape flavored. So these are the different formulations that are available today. Next slide, please. It came to Canada with a track record in Europe because it was approved for pediatrics 4 years ago, and there's over 2 million courses prior to it receiving the indication in August of 2021. Next slide, please. It's available in 121 countries now. You can see it's not available in the US, which is too bad. And it's been used over 213 million times as of August of 2021. So if there was any concern post-marketing, it would have been picked up by now. And there's been nothing really that's picked up that would be of any safety concern. Next slide, please. Now, in order to get the label for pediatrics, first of all, they have to see that it's safe and say, well, it's going to be useful to study. And then secondly, the efficacy has to be extrapolated from adults. So that's why I was emphasizing that adults and children, both with allergic rhinitis and urticaria, it's the same pathophysiology, and extrapolated data is therefore acceptable. And then you have to look at the dose, because the dose in adults, you can see, is different than the pediatric dose. And when they looked at the pediatric dose using a model, it came out best at 10 milligram for all the age groups. If you look at the safety study, and this was a 250 patient, 500 because one is placebo and one is treatment, they were looking for treatment emergent side effects if there was anything that was unusual in the pediatric population with regard to safety. And there was no difference between Bilistine and placebo in the number of adverse events. So because of that, Bilistine was approved, as I mentioned recently. Next slide, please. Now, I just want to go over a study because if you read the product monograph, it states that patients should take Bilistine 1 hour before or 2 hours after eating. That means on an empty stomach. And that's for maximal absorption. But what would the effect be if they took it with food? Because patients often ask you that. I was asked that last week, actually, by a patient. Next slide. This was a study that was published recently at a meeting and presented. It addresses the issue, looking at the wheal and flare response. When we look at an antihistamine potency, one way of measuring it is to do intradermal injections of histamine and measure the histamine wheal and flare. With an antihistamine, the wheal and flare should be suppressed. So you're looking at the potency in terms of onset of action, which you can look at, and in terms of wheal and flare suppression by using a histamine skin test. What they did in this study was they either fasted people and gave them Bilistine, or fed people with a moderate fat breakfast and then gave them Bilistine. And they looked at the effect of the histamine skin test. And next slide shows that when you have a potent antihistamine, you still see almost identical effectiveness with regard to wheal and flare suppression when you're looking at this model and you're looking at normal volunteers that ate and normal volunteers that fasted. So even though you absorb a third less, it seems to have almost an identical curve. Now, this is just for your own information. It's still on the product monograph to take it on an empty stomach. I just would like you to be aware of this. Next slide, please. I want to talk for a few minutes on safety and tolerability. Next slide, please. Again, when we look at sedation of antihistamines, Bilistine is the same as placebo in all clinical trials. Rapidodine is the next with some sedation picked up in occasional trials, and cetirizine is the most sedative of the three antihistamines. And this is from product monograph data. Next slide, please. If you look at subjects treated with Bilistine, you see that there is really no side effect that was more common than placebo. So if you look at abdominal discomfort, dizziness, headache, and somnolence, there was no significant difference. The side effect profile was equal to placebo. Next slide, please. If we look at sedating antihistamines, that's first generation antihistamines, we can look at it in the model where we're trying to see if it crosses the blood-brain barrier. And this is the PET scan model shown on this slide. So this looks at the histamine H1 receptor occupancy using PET scan. So you can see it light up if it crosses the blood-brain barrier. So if you look at the top, you see all the colors. That's if you're taking a first-generation antihistamine. And you can see that some antihistamines surprisingly bind almost 100% to histamine receptors in the brain, and most of them are over 50%. And that includes ones that are available in Canada: hydroxyzine, chlorpheniramine, diphenhydramine, and ketodifid. On the other hand, if you look at Bilistine, you see that it is not sedating, and similarly for fexofenadine, they're the least sedating, whereas the others are a little bit higher if you look at histamine receptor occupancy. You do not see rapidodine on this slide because it wasn't studied on this slide, but it would be low sedating as well. Next slide, please. Again, 2/3 is eliminated in the feces, 1/3 by the kidney. So it's not until end-stage renal failure that you're going to see accumulation. That's why it's safe for people with renal impairment. And the bioavailability is quite high, which is one reason why you see fasting and fed, there's not much difference. Next slide, please. So again, an ideal antihistamine is firstly potent. It has to work fast. It has to be effective. And you want the fewest drug-drug interactions. You don't want non-specific effects like anticholinergic effects. You will want safety concerns with regard to sedatives, with regard to cardiac safety, and with regard to psychomotor retardation. And finally, you don't want a drug that has tachyphylaxis. And this is what we're looking at with the different antihistamines. And this is what we're trying to compare with the differences between these newer second-generation non-sedating, non-impairing antihistamines. Next slide, please. So we have a case of a woman 42 years old who has severe seasonal allergies, but she's a delivery driver. She's tried over-the-counter antihistamines, but does not find them to be effective. She probably has just taken them over the counter, bought them, and taken them occasionally and not taken them every day like you need to. She's taken prescription antihistamines, but they seem to make her drowsy, and she doesn't like nasal steroids. Next slide. A lot of people don't like the word steroids, although they're very safe. She has several comorbid conditions and several medications that she's taking, including a statin. Next slide, please. So which second generation antihistamine could you choose? Well, if we consider the patient's needs, she's a delivery driver. So we want to use a drug that does not cause drowsiness or does not impair her driving. She's taking polypharmacy because she has comorbid conditions. And so you would want a drug that has the fewest potential for drug-drug interactions. And she has reduced renal failure. So you would like an antihistamine that would be safe in people with lower renal failure. Next slide, please. So Bilistine would be a good choice for this patient. It's acceptable for patients with renal impairment. It's not metabolized. No dose adjustments are needed for organ dysfunction. And at the recommended 20 milligram dose, the side effect profile is equal to placebo. Even with updosing to 40 milligram, it is as well, which we could talk about when we do urticaria. Next slide, please. So we want to start treating 1 week before the allergy season, and then we treat with an antihistamine throughout the season in order to get optimal benefit from an antihistamine. And this is important in patients that you treat with allergic rhinitis. Often you can combine it with a nasal steroid as well, if necessary. Next slide, please. I'd like to thank you for listening to the discussion, and it's my privilege and pleasure to introduce Jaggi Rao. Again, Jaggi's a professor in the Division of Dermatology and Cutaneous Sciences at the University of Alberta. He's the founder and medical director of Telederm, which is giving very important advice to patients to try to keep them out of the emergency. And Jaggi's a board certified dermatologist. I'm a board certified allergist immunologist. So we're a little different, but very similar, to be honest with you. So with that, I'm going to turn it over to you, Jaggi, and I'll come back on after for the discussion. Thanks, appreciate it.
Thank you very much, Gord, for that kind introduction. I would say that I'd like to be similar to Dr. Sussman. He is a wonderful teacher and a legend in his field, and something that we all aspire to be. When you're a specialist, you want to be like Dr. Sussman. As you can see, he puts things in a very, very nice, easy, explainable way. And that's the reason why he was the representative for Canada at the international guidelines for urticaria. And we'll be talking a little bit more about that as I go through a couple of cases. But let's go ahead. If you don't mind, Roxanne, I'm going to go ahead and ask a polling question first for the crowd. So here is that question. According to international guidelines for urticaria, what should be first line for the treatment of urticaria? So what is the first line treatment of urticaria? Please select one of the following and we'll discuss it. Okay, so most of you said second generation antihistamines, and just a couple of said first generation, and some said systemic corticosteroids. The correct answer, according to the international guidelines, is second generation antihistamines. And you heard from the man himself, Dr. Sussman agrees with that. He did indeed present that to some degree. And I'm going to talk to you a little bit about that as well as it pertains to the concept of urticaria. So with that, let's see if we can advance. Okay, so we're going to talk the remainder of the hour here about chronic urticaria in kids and adults. If you have any questions, please don't hesitate to put it into the chat window. We'll try our best to answer each and every one of them towards the end. Firstly, what is urticaria? Urticaria is a chronic condition, usually of the skin. It can be acute as well, but typically it's chronic, and it's characterized by these red, swollen, itchy hives that you can see literally anywhere in the skin can represent this. And typically there will be a little bit of pallor in the center. And as you go towards the periphery, there will be a little bit more accentuation of erythema. And what's happening underneath the skin is actually vascular dilatation. So we know that the blood vessels in the dermis, when they encounter certain chemical mediators such as histamine, will become bigger. When they become enlarged, there's more blood flow to the area. That blood flow will translate into redness, some blanchable erythema, we call it, and then also a little bit of pallor, depending on where we're looking and how much the concentration of blood vessels are. So we got a little bit of pallor and we got a little bit of erythema. One thing we'll also have when the blood vessels are enlarged is extravasation or release of a number of different materials from the blood vessel itself into the interstitium. One of the things that's released is fluid. So when fluid gets released, then that can cause a bit of a pressure phenomenon. The pressure will push up against sensory nerves and you get that feeling of itch. So whenever you have these hives, you feel like itching and it looks like it's fluid filled, and indeed it is, but the fluid isn't free fluid. You wouldn't be able to pop this and get out extrude any fluid as you would with a blister, because the plane of where the fluid isn't in the dermal epidermal junction. It's beneath that, it's within the interstitium. It's kind of like a wet carpet. So you have all of these fibers of the dermis, and then in between that you have this edema. The other thing that will happen, of course, is release of some more factors such as histamine that cause itch, and the reason that happens is because they tend to activate the sensory nerves that are there. Now, if the blood vessel dilatation is really, really great, you can actually have all of these hives go ahead and coalesce. So instead of having individual hives like this, they can sometimes merge together. Now this is called urticaria. If the process is deeper within the subcutaneous fat, then we call it something different. We call it angioedema. And indeed, angioedema can occur in about 40% of patients who have urticaria and hives. The only difference is the fact that we have deeper blood vessels that are becoming very dilated, so they become leaky, and that causes a little bit more of the edema. I was about to say inflammation, but in fact, it's not really inflammation. If you took a biopsy, you'll see that there's no inflammatory cells, at least earlier on. So if you count the number of lymphocytes and neutrophils, you'd expect it to be normal compared to the surrounding skin for both urticaria and angioedema. And one of the differential diagnoses under the microscope for urticaria is normal skin. So really, there's no point in really biopsying it unless, of course, you're ruling out other things like urticarial vasculitis and so forth. One other thing important to mention, when the fluid is in the dermis, such as you'd see with urticaria, it will last for 24 hours or less. Most of the time, it's far less. So you'll see these hives over here will go away within about an hour or two, but definitely less than 1 day or 24 hours. For angioedema, it's going to be a little bit longer. So normally for angioedema, it'll be less than 72 hours or 3 days. And the reason is there's a lot more fluid that's there. And also angioedema doesn't itch as much as urticaria does. Instead, it can be sometimes quite tender and painful if that fluid that's deeper and in more excess than urticaria pushes against some of the deeper sensory nerves, then you're going to get a little bit of a pain sensation. And indeed, it can even be dangerous if that swelling pushes up against very important structures such as your trachea. So we do definitely have to be very sensitive and mindful for where that interstitial edema is. Is it urticaria in the dermis, or is it angioedema a little bit deeper? Now, both of these will affect adult women a bit more frequently than it affects adult men. For children, it's about 1-to-1. So for males and females are affected pretty much the same. And often we use the term chronic versus acute. Acute means that the urticaria or angioedema is technically less than 6 weeks in duration. That doesn't mean that the lesion is there in the same spot for 6 weeks. It means that the condition has been there for 6 weeks. So looking at this square example, this clinical example here, these individual papules and plaques we mentioned will disappear and reappear either in the same spot or somewhere else within 24 hours. So they go away within 24 hours and then they can recur. However, if that waxing and waning continues on for greater than 6 weeks duration, we now don't call it acute urticaria, we call it chronic urticaria. And chronic urticaria most of the time is spontaneous. That means it's idiopathic. We don't know what is causing it to progress. What we do feel is that most of the time after the 6 weeks, it's going to progress because of an immune-mediated phenomenon. Think of it kind of like a fire. So if you want to go ahead and burn a fire, we would take wood, and then you'd need to have some type of an igniter, and you need to have fuel. And then once you get that going, let's say it's a campfire, there will reach a point where it can actually go by itself. And so that perpetuity of it, at least for urticaria, happens after 6 weeks. So people ask me, the patients will come in and they'll say, hey, should I do some allergy testing? After 6 weeks, if the urticaria is still continuing, I would say no. It's like a fire that's kindling. Let's put it out. And maybe there's some reason to do patch testing later. We'll ask Dr. Sussman this, because maybe we want to identify what could have been an initial cause, but it's not the perpetuating cause anymore. So really, there's no point in doing it in a certain interval because you'll get a lot of false positives, and that's not really helpful to anybody. So initially, within 6 weeks, definitely inducible. After 6 weeks duration, urticaria and angioedema is typically going to be chronic and spontaneous. There are a few inducible chronic urticarias. These usually are influenced by physical stimuli, such as exercise. There's a form called cholinergic urticaria. There's also solar urticaria and a number of other things. But generally speaking, it will be spontaneous or idiopathic. Okay, let's go to the next slide, please. I might ask you to do this. Okay, yeah, so a little bit of statistics. So epidemiology, chronic urticaria prevalence is usually pretty low, but if you look at the population, they say 0.5 to 1.5% of adults and children, which is actually quite large compared to a number of other skin findings that we can see. 20% of chronic urticaria may have a proven trigger, in which case we call it chronic inducible urticaria in both adults and kids. But the remaining 80% are, as we mentioned, spontaneous. They don't have a known detectable cause, and we call that idiopathic urticaria. So the resolution rates also differ with adults versus children. For adults, the spontaneous resolution within 5 years is about 30 to 50%. So imagine, you know how difficult it is for a patient to have urticaria. Usually they can't sleep very well, they can't concentrate very well because they're very, very itchy. And imagine that going on for years. Well, about 50% will resolve by 5 years. So people can be suffering for a long period of time, and in some cases, much, much longer, even decades of duration. For children, 50% of the pediatric cases with CSU will resolve within about 5 years. So it's about the same, if not a little bit better prognosis with children. But as you know, if you're a parent of a child, if your child has urticaria, it's not only going to affect the child, it's going to affect everybody who cares for the child and is around the child. So both adults and children, it does take a long time to remit. And if it does happen, we really want to treat it as aggressively earlier on as possible. Now, we won't go through too much detail of actually what happens, but we actually know that it has to do with this particular cell that's blue in color. This basophilic cell is called a mast cell. It's a modified white blood cell. And you can see that it has, in addition to its nucleus, a lot of these little granules inside it. So it's loaded with all of these little vesicular granules. Those granules contain a number of different items. Some of them are vasoactive mediators, so when released, they cause vascular dilatation. Some of them are proteases. Some of them are also lipid mediators, and some are chemotactic factors, meaning that they draw in inflammatory cells. And all this relates to cytokine release. So when cytokines are released, you have a number of different physiologic events that occurred with the skin. This whole mast cell degranulation is related to the immune pathway and sometimes the autoimmune pathway. So normally what will happen is if your body is introduced to some type of an allergen or an irritant, some type of a stimulus like that, if it is something that is microscopic, typically your immunoglobulin G or immunoglobulin E or IgE antibodies will go ahead and try to sequester that. It'll try to touch and grab onto the antigens and then present it to the mast cell. When it's presented to the mast cell will dehiss when there's a certain concentration and release all of these mediators proteases, and histamine that will cause what we know and do not enjoy as urticaria and angioedema. Now, we talked about how chronic spontaneous urticaria will affect quality of life. Here we have DLQI, Dermatology Life Quality Index score on the y-axis, and on the x-axis we have a number of different conditions. Well, itchiness, pruritus, and chronic urticaria always rank the highest of all conditions of the skin, including eczemas, psoriasis, and so forth, because it really disrupts quality of life. In some cases, patients are even depressed or even rarely suicidal because of the fact that they can't get relief with this. Fortunately, there's a lot of good ways to relieve this, and I'm going to show you some, at least as it pertains to today's discussion. So children, of course, it's even worse. So itching is definitely the most disturbing symptom, and if they can't sleep, then it goes ahead and it feeds the negative and poor DLQI. So that means daily grogginess, fatigue, irritability, poor school performance. Sometimes it leads to learning difficulties. There's a certain time in one's life where they can learn maximally, and if that's impaired in any way, then people tend to grow up with cognitive faculty problems, concentration issues, and memory disorders. So this is very important to kind of capture, especially in children very early. And what we didn't talk about in too much detail is it of course affects caregivers, teachers, and those who are managing and helping these children. The goal of treating patients with urticaria should be to treat until the disease is completely gone, meaning there is complete resolution of symptoms and there is no longer any itch. And if you go to the guidelines, now Dr. Sussman had talked about this, and I mentioned we owe him a gratitude because he was our Canadian representative at the International Congress that came up with these guidelines. They say to start with a second generation antihistamine, and if it's inadequate in about 2 to 4 weeks, they say to increase the dose, not twice, not threefold, but indeed fourfold the dose. And so that is found to be safe with the second generation antihistamines, in particular with Bilistine or Blackstone. It has been in the adult form and in children's forms, going up dosing to fourfold the dose is extremely safe. Indeed, some dermatologists and allergists go even higher than that, but because the international guidelines say fourfold max, that's what we stick with for medical legal support, but also efficacy and safety. They also do say over here that under the supervision of a specialist, you may wish to consider bursts of corticosteroids systemically. And they do help. The problem is often when they wear out, people will go back to where they were with regards to baseline itch and sometimes even rebound. They'll get even a little bit worse. So if anything, it can be said that steroids mask the symptoms. They do have their place in keeping people a little bit more comfortable, but I would recommend at least medical legally getting some type of support from or supervision from a specialist. Now, if you do come to a specialist after there's no improvement, and in some cases there is not, with the fourfold up dosing, what we would often consider, according to these guidelines, is omalizumab. So omalizumab is a monoclonal antibody. It's a biologic agent against IgE. So it's an IgE antagonist, and you saw that IgE is responsible for the presentation of antigens to the mast cells. If those are sequestered, then most times, 95+% of times, that whole process will stop and urticaria and angioedema will resolve. If it doesn't, then there's more advanced medications, which don't have, they have their risks onto their own. They don't not have side effects, double negative, and one includes cyclosporin. But if you're talking about omalizumab and cyclosporin at this point, I would definitely refer to a specialist. Updosing the antihistamine has been found to be extremely effective. And this is a really nice study of about 24 people that take a look at what kind of effect is there if you did either updose one antihistamine to fourfold the dose, which is in purple, or do you do 3 antihistamines at double the dose, or do you do 2 antihistamines at double the dose? Definitely you'll get some improvement. So the pruritus reduction, the higher the better. And you can see that there's improvement for all of them, but the best improvement happens to be fourfold of the same antihistamine. And that's awesome because the patient is already comfortable with the antihistamine. They just have to take more of it. And what's recommended is fourfold. When I do it, prescribe it or recommend it, I typically recommend 2 pills twice a day. Now, this just shows you the sedating effect of first-generation antihistamines. So you give it, and one of the positives is that patients look like they're sleeping. So they might be groggy, fatigued, and then they look like they're sleeping. But if you actually measure their brain waves, you'll see that they're not going into REM sleep. So here is an example of somebody who does not have first-generation antihistamines on board, and you can see there's periods of activity where the brain is quite active, but then not so much. This part where it's not so active, it's more flatlined brain activity, that's when they're having REM sleep or rapid eye movement sleep. And that's believed to be what's necessary for wakefulness, to make you alert while you're awake. Now let's take a look at that same brainwave while you're sleeping with first generation antihistamines, and you'll see that there's actually very little sleep that's in the REM pattern. So not only is it delayed, it comes later on in the sleep cycle, but it's also reduced. And so when that happens, when a patient actually wakes up, they're going to be quite drowsy. So they look for all intents and purposes like they're sleeping, but they're not having that REM brain activity, which causes daytime somnolence. Now, second generation antihistamines for that reason are recommended largely over the first generations. But which one should you use? So the ones that are prescription based in Canada include Bilistine, Cetirizine, and Rupatadine. And you can see that, well, it depends on the dose for Cetirizine. I believe it's 20 milligrams and higher is prescription based, whereas the 10 milligrams is over the counter. And then we're also going to talk a little bit about pediatric formulations. In this study of 24 healthy volunteers, we kind of compared them head to head. So we compared Bilistine to Arius, which is Desloratadine, and Rupall, which is Rupatadine. And let me show you the results of this. And they evaluated the ability to reduce hives, so wheals and flares. Well, this might not be surprising to you for those who prescribe Bilistine, but it was the winner. So even with a single dose of this and then injection of histamine into the system, you'll see that it beat out both Desloratadine and Rupatadine with respect to wheals as well as flares. So the higher the number, the better in terms of improvement. And you can see it's significantly better than the others and the placebo, of course. And then if we take a look at itch perception, the lower the number, the better. You can see this red line is Bilistine, significantly lower than both Desloratadine and Rupatadine. There are a number of different phase 3 studies that have been done in adults for Bilistine, not only demonstrating its efficacy, but also demonstrating its safety, tolerability, and duration of action. So even at higher doses, it has been found to be extremely effective and very, very safe. Now, this updosing experiment demonstrated the efficacy in chronic urticaria. So here in pink, we see Desloratadine, which is Arius, and we see Cetirizine in both 10 milligrams and 20 milligram dosing. And then so over the counter and the prescription dosing. And then we see Bilistine at twice a day. So remember, it's 20 milligrams once a day is the indicated dose. This is double that, and then we see quadruple that. We're getting even more of a greater effect. But even at double, it significantly outperforms the others that we see here with respect to chronic urticaria. So updosing definitely makes a difference. And you can either go 2 or 4. I don't do 2 anymore personally, I just go straight to 4. If you take a look at the incidence of adverse events, it's the same as placebo, if not even better. So GI disorders, excellent with Blackstone. You don't have that abdominal pain that you would see with other antihistamines. And nervous system disorders, including the somnolence, headaches, etc., that you could get, it's in fact fantastic. It's equivalent to placebo. There's no statistical difference. And same thing for children. So here, this study took a look at children, and you can see that there's no difference between Bilistine and placebo in the number of treatment emergent adverse events. In fact, it was considered to be exactly the same and very, very, very safe. Okay. Let me show you finally just putting a couple of cases together. Here we have an adult patient who presented to one of our regional emergency rooms in Edmonton, 24-year-old university student, and she had hives for more than 6 weeks. Indeed, it was 12 weeks on the trunk and extremity, substantial swelling also to the lips on a daily basis, and very, very itchy, affected all aspects of her life, including her social life, self-image, and sleep. The diagnosis was made of angioedema and urticaria. Here are some images of what was sent to me. And you can see that there has a classic hives, the edema there. You have that flare of erythema, and you have the wheals, and you have some central pallor, and a very, very itchy. Question is, how long do they last? Individually, it would be less than 24 hours. And in total, this concept has been lasting for more than 12 weeks. Her previous treatment and current treatment are as follows. She wasn't treated with anything, no known allergies. Sometimes she would take a Benadryl up to 3 times a day. And this has been shown to control the itch and swelling, but only temporarily. And then the lesions tend to recur. And of course, she gets a lot of sedation with that. And it takes a long time to kick in. While in the emergency room, they went ahead and they sent this telederm consult to me. So I took a look at the patient's images and history. And following these guidelines that Dr. Sussman was held, he actually did quite a bit with respect to this, even more than a lot of the other doctors who were part of this group. So we owe him a great thanks. I actually went directly to 4-fold the dose of Blackstone. So I bypassed the original one because I wanted to, I know it's safe, I have a lot of experience with it, and I'll show you what happened. So I recommended discontinuation of Benadryl, started Bilistine at 4-fold the dose, and the way I do it is 2 pills twice a day. And I did it for 7 days and then asked them to follow up in my clinic. And the reason I chose it, I have a lot of good comfort and experience with this. I know it's very, very safe. We had great experts like Dr. Sussman already advocate this, and we know that it's tolerable. So, and if it didn't work, at least then I could go ahead and prescribe or enroll the patient onto omalizumab. So I saved a lot of time. So 1 week later, the condition had greatly improved. Everything cleared, decreased in terms of intensity of the itch, and no adverse events. So her quality of life was quite improved, and had she actually, wherever she had had deficits, all of it was better, but she was still getting some of these hives. So you can see that episodically now instead of very frequently. So on the left was an example of the urticaria and angioedema. And then all of a sudden, whenever she would take the 2 Blackstone, which I told her to take, she took this herself. You can see that those signs and symptoms go away. So everything goes back to normal very, very quickly, even within half an hour to an hour. So when I saw the patient back, I told him continue with the 40 milligrams BID, that 80 milligrams a day, 4-fold a dose for 30 more days, and then follow up with me. And this is how I write the prescription. So I typically write Blackstone 20 milligrams a day for 30 days, but may take up to 80 milligrams a day. And I put here, nota bene, or please note, this is very, very safe. Since I've been doing that, I haven't had too many callbacks from pharmacists, and it means that I recognize this is higher than the indicated dose. It is technically off-label, but boy, does it work, and it's very safe. I will take the responsibility because that's what the international guidelines say. So I have some medical legal backing. 1 month later, the patient came back, no hives, no swelling, no itch, no nothing. And what I recommended then is to continue with it, but do it at the indicated dose for an additional 30 days, and then just as needed, PRN thereafter. Okay, and then we can talk about with the patient referral for allergy testing and ultimately discharge back. Very quickly, just 2 slides here to illustrate pediatric case. This is a 9-year-old boy, had allergies for sure. They got a new dog. He would break out every time that he would come in contact with the dog, and this condition was present for 2 months, which is greater than the 6 weeks. So we call this chronic spontaneous urticaria. He tried over-the-counter Benadryl, but it made him quite drowsy and irritable. So we switched it over to Bilistine. And remember, there's 2 formulations of this. There is the liquid, the oral suspension, and then there's this quick melt, which is also available. And the quick melt is a nice grape flavor. The oral suspension is raspberry flavor, and it actually, both of them work really well. This is how I write them. So either it's always children's Blackstone, either oral solution or quick melt tablets. It's 10 milligrams a day as needed. And sometimes I'll actually put very specifically for 30 days. And I do also say the same thing. They can updose this. They can go to 2 pills twice a day if needed, and or the 4-fold the dose, and that works quite well. This is what this boy did, and his hives and itch were completely resolved within 20 minutes of treatment each time. and it no longer impacts his daily life, and his sleep is excellent.
So we
with
have
that,
time for a little bit of questions. We do have questions from the audience. So again, please submit your questions on the question chat pane. If there's any questions that you think about after the webinar, you can always send them to info@rbcconsultants.com. We want to thank again Miravo for making this educational event possible. So in terms of questions, what antihistamines would you use in someone under 2 years of age?
Jackie, I want to thank you. It was very nice of all the kind words, firstly. Why don't you start with what antihistamine would you use? I think theoretically they're all off-label under 2 years of age. Good
I would
question.
use, I have no hesitation using the new children's Blackstone. I've done it several times for children, but you know, usually under 2 years of age, we don't see a lot of urticaria. I think that maybe the immune system isn't mature enough, but if I do see it or they're experiencing that itch, I have no hesitation using Blackstone.
The only thing I wouldn't use is Benadryl. I wouldn't use a first generation antihistamine diphenhydramine. The second generation, either Arius liquid or Bilistine liquid, not Bilistine liquid or Rapidine liquid to me would be fine. Any second generation antihistamine, even though it's off label, is safe.
Another question, can we use Blackstone in pregnant and breastfeeding women?
The answer is probably you can, but the safety data isn't there. So in pregnancy, we would use Reactin. Cetirizine isn't what we use in pregnancy, or Loratadine or Claritin.
I agree. There's no point in risking it. I mean, even though we know it's going to be safe, and I've had people accidentally use it, because it's not on the product monograph, you don't want to open yourself to medical legal risk.
Breastfeeding, there's no issue. A little bit of all the antihistamines could be passed in the breast milk, but there's no harm to the baby.
What is the highest dose per day that was studied?
With Bilistine, are we talking about? Jackie, you want to comment on the highest dose you would use?
I know that I've seen reports of 10, so 10-fold the dose even. But again, I don't know if that's actually been published. I know that anecdotally people have used it at that high.
They studied the 10 times the dose for cardiac safety. So, you know, there has been studies with 10 times the dose of Bilistine. And we're not really concerned about safety. We're more concerned about safety with first generation than we are with second generation. So even though we say 4 times the dose, there's no harm in going higher. It's just that you really don't see much benefit. So the top dose that we generally use is 4 times.
Dr. Sussman, do children grow out of allergic rhinitis as they get older and their facial ear canal anatomy changes?
Yeah, often allergic rhinitis is outgrown, you know, so you see people and then you see them back again 30 years later and they've outgrown their allergies. So often they will outgrow their allergies. I just want to mention with skin testing for chronic urticaria, most allergists would not do skin tests, but I do food allergy tests, and the only reason you get away with it is because it's not an allergy. So the food skin tests are generally always negative. And then someone will ask, well, what if you have a positive test? I'll ignore it because you know it's not a food allergy. It's much easier showing people that they're not allergic than just telling them, in my experience.
I guess, Dr. Rao, thoughts on Zolaire for chronic urticaria?
Zolaire is excellent for patients who don't respond or are not adequately responding to the 4-fold dose of the antihistamine second generation. I think it's certainly the go-to. That's what the guidelines say, and practically speaking, absolutely. In my experience, about 95% of cases can actually be resolved by using 6 months to a year of Zolaire.
Yeah, Zolaire was a game-changing treatment for chronic urticaria. It really changed the way we treat, and we should all want to treat it because it's fun to treat now.
What's the risk of developing asthma if a child has eczema and allergic rhinitis?
I think the risk is higher. I don't think you can give an exact number, but the usual atopic march is atopic dermatitis, asthma, and allergic rhinitis. And food allergy is probably before allergic rhinitis. So people are sensitized to foods when generally they have atopic dermatitis. So they're all comorbidities. They often all occur together, and they generally occur in the young age, like the pediatric age group.
Would you use Bilistine in a patient on diltiazem?
Yeah, diltiazem, you want to answer that, Jackie? Why don't you handle it?
Yeah, I haven't had any issues. We have several patients on both. No problem.
Again, drugs that prolong the QT interval, you don't have to worry about. I don't know if diltiazem does, but again, cardiac safety is to me not a concern with Bilistine. I would use it ahead of any of the other antihistamines because it's been studied.
Also, in what situations may you do any autoimmune workup for CSU?
So the workup for chronic spontaneous urticaria is generally a CBC and CRP. And we do a CRP because there are some groups of people that they're sick, generally fever, joint pain, fatigue, and systemic symptoms. And we treat with a different drug. It's treated with an anti-IL-1 or colchicine, whereas chronic urticaria, we treat with antihistamine and Zolaire. So we recommend this in the guidelines just to do a CRP. Some people will do thyroid antibodies. I do thyroid antibodies. About 25% of people have thyroid antibodies. And we think that the thyroid antibodies are actually some of the antibodies that will be responsible for this mast cell degranulation. So I do thyroid antibodies. Jackie, what test do you do?
No, I don't do any of those. Practically speaking, I haven't found them too useful. However, if the person's urticaria is lasting more than 24 hours, like the hives are lasting a long time, I would consider a biopsy. It might be representative of a vasculitis that in turn could be representative of an autoimmune disorder, connective tissue disease, or something in that category. So it might be worthwhile to do it at that point, but generally we don't do it in dermatology.
We used to do a $5,000 workup for chronic urticaria. We don't do that anymore.
Well, unfortunately, that's all the time we have. So we would like to thank Dr. Rao and Dr. Sussman for a very clinically practical and applicable presentation. And we'd also like to thank all of you for joining us this evening. Good night, everybody.
Good night. Thanks everyone.
Thank you.
Bart. Good night,
Bye-bye.
everyone.
Thanks, Jackie.